Good afternoon. This webinar series was developed by the Colorado Older Adult Falls Prevention Coalition, specifically the community-based Older Adult Falls Prevention Team. Members of the team represent hospitals, public health, and other organizations. The team's mission is to reduce the risk of falls through education, raising awareness, advocacy, and improving access to resources. The role of the team is to provide leadership and guidance for local falls prevention efforts. This is the fourth in a series of 7 webinars titled Medication Review and Management.
Our first presenter today will be Leah Fitzgerald, a pharmacist at Swedish Medical Center.
Hello, my name is Leah Fitzgerald. I'm a pharmacist at Swedish Medical Center. Just to give you a little bit of background, I work primarily in the inpatient setting, and most of my career has been in that direction. But recently I've participated in a community-based program called Stepping On, which is a grant-funded program designed to help community-dwelling older adults reduce their risk of fall, improve self-management, and increase quality of life. And so I'm here today to share with you some of the things that I have learned regarding medication use and fall risk in elderly patients. So there's 4 main things that I hope we're able to accomplish in this presentation. Number 1 is to understand fall risk as it relates to medication use in the elderly, to identify classes of medications, both prescription and over-the-counter, that might contribute to an increased risk of falls in older adults, and to discuss medication management strategies that decrease fall risk. And finally, we'll talk about the role a pharmacist can play in reducing medication-related falls in the elderly. So we know that increasing the number of medications used by an older adult increases the risk of falling. But what is that risk and how much is it increased? There was a study done out of the University of North Carolina in 2008 that found that patients who were on 4 or more medications of any type, so this included both prescription and over-the-counter medications, had an increased risk of falling of 30%. There's also been studies that have shown similar patterns in nursing home residents. The more meds a patient is on, the more their risk of falling increases. It's difficult to look at falls and define them as an adverse event because there's not a very good definition of fall as an adverse effect of medication. And falls are not regularly recognized as side effects or reported in clinical trials. So there's really no way to get a good grasp as far as a particular medication, what the percentage or increased risk of fall would be with that medication. So that's definitely one of the challenges when we're looking at medications and fall risk in the elderly that we face. Also, you have to remember that reasons for falls are usually multifactorial, so you can't always point the finger at one particular thing, in this case, that being a medication. So now we're just going to talk, I'm just going to do a general overview of classes of medications that have been most closely identified with an increased risk of fall in patients. First, we'll start with the antidepressants. The most common categories used of antidepressants are the SSRIs and the TCAs, or tricyclics. Some examples of names of medications that you might see patients taking that fall into this category are Paxil, Prozac, Celexa, and amitriptyline is one of the tricyclic antidepressants. And what we have seen in antidepressants in elderly patients is that when they're on these medications, their risk of fall increases 1.2 to 6-fold is what's been demonstrated. We've also seen that patients within the first 2 weeks of starting therapy have an increased risk of hip fracture. And we've also seen that the risk of fall remains elevated during long-term use and is dose-dependent. So there's definitely been an association not with only being on these medications, but to higher the dose, the higher the risk of fall. The second category of medications that we're going to talk about are anti-anxiety medications or benzodiazepines. Some common names of these types of medications include Xanax, Valium, Ativan, and Klonopin. Again, we've seen an increased risk of falls when patients start these medications and when they're used long-term, regardless of the medication half-life. I believe that thinking of some of the newer medications, such as Ativan or Xanax, or that their shorter half-life might have a better side effect profile. But what we've seen is that even on these medications that are shorter acting, they still have the risk or the increased risk of falling. Also, the same study that we were looking at before showed that 2 or more benzodiazepines, when patients take those, that they increase their risk of hip fracture again twofold. And then the last category that I'm going to touch on in general are sleeping medications. So the benzodiazepines, the anti-anxiety medications we just talked about, are often used as sleep aids, as well as some of the newer agents, Ambien, Sonata, and Lunesta. In the Ambien, I think there was some thinking that, again, because this was a newer agent, that it might have a better side effect profile, especially in the elderly population. But what we've really seen through common use out in the community, the Ambien is just as risky as the benzodiazepine class that we talked about before. And what we want to really remember about these categories of medications is that their common denominator is that they all, in some way or another, depress the central nervous system, which makes a patient less alert and makes them slower to react to changes in their environment. And then it just follows along that, of course, they're going to be at increased risk of fall in that scenario. Other classes of medications that have been associated with fall risk include the antipsychotics, cardiovascular medications, pain medications, and antihistamines, especially over-the-counter medications. And the most common antihistamine that's bought over-the-counter is Benadryl or diphenhydramine. And it's important to remember that the antihistamines, especially this time of year, are not only just their own medication, but they're all often combined in cough and cold preparations. So patients may be putting themselves at a risk and taking an antihistamine without even realizing it when they've bought a multi-symptom cold medication from their local drugstore. I've included down here at the bottom a list of medications that have been associated with the increased risk of fall. This list comes from that same University of North Carolina study that I talked about earlier, showing that 4 or more medications increases a patient's risk of fall by 30%. It's a pretty extensive and long list, but there is a link here if you want to go to that and look at that for your reference. So of these classes of medications that we just looked at, our question and what we're here to talk about today is, why do these medications increase fall risk? And the number one reason is due to their side effect profile. And all of these medications, these are some of the most common side effects, or some of the ones that they have most in common. And that's dizziness, drowsiness, confusion, orthostatic hypotension, and tremor. All of these side effects can work to increase a patient's risk of fall. Again, we talked about the central nervous system depression, making patients less alert, making them less able to react to changes around them in their environment. And then also, medications due to drug interactions and additive side effects can also work together to increase fall risk. So for management strategies, now that we know and have a better understanding of medications, what their risk of fall is, why that happens, here are some things that I've seen that we can put into place to help our patients decrease their risk of fall. Number one is using the lowest effective dose. Remember, there is evidence out there that just lowering the dose can help to lower somebody's risk of fall. Minimize the number of medications a patient is taking. I always tell the patients in the Cephion program, based on that one study, 4 is the magic number, and any of you who work with elderly population know that you reach that number really, really quickly. But again, looking at a patient's medications to hopefully reduce duplications and minimize their medications so they're only taking the ones that are really essential. We need to make sure that we as caregivers and patients themselves have an awareness of the increasing risk of falls, especially when they're starting a new medication. And we need to help our patients be aware of and plan for side effects of their new medications and the medications they're already taking. So some of that would include more frequent monitoring by caregivers, by patients themselves when they're starting new medications, making sure that you're checking in on them a little more frequently as they're adjusting to a new medication or a new dose, educating the patient and the caregiver about what to expect. We want patients to understand the side effects that they should expect and that are reasonable, and we also want them to understand when they need to contact their prescriber because they may be experiencing a side effect that's really unexpected or greater than they should, and in that case they need to be able to contact their caregiver or their primary care physician. And one thing that I always make sure to tell the patients in the Stepping On program is not to begin any new medications or increase their doses just before vacation or considering this type of year the holidays. You know, when you're talking about a vacation and you're going to be in a new environment and new places, you definitely don't want to also throw in there a new medication or a higher dose that your body's still trying to adjust to. Same thing with holidays, with people rushing around and being in places they're not usually used to doing. It's always a good idea to make sure that starting new medications and dose changes are done when the patient is in their normal environment and where they can be safest. Lastly, for pharmacist intervention, these are some of the things that I believe a pharmacist can do to work with patients and caregivers to help reduce their risk of fall as far as being related to their medications. Number one, and most importantly, is that all patients need to have a personal medication card or list. This doesn't have to be anything fancy. This is a simple list of their medications with their name, the dose, and how and why they take it. It's really important that patients understand their dose and they understand why they're taking which medication. Pharmacists are a great source for education. They can help to inform patients and caregivers about side effects, strategies to manage those side effects, and again, they can help patients recognize when a doctor needs to be called because of side effects related to a medication. I also believe that pharmacists are in a unique position to develop a relationship with their patients because they see these patients more frequently. I always encourage that patients to seek out pharmacists who will actually take the time to talk to them, to review their list of medications, to help them understand their side effects. And patients should expect this from their pharmacist, and if they feel that they're in a place where they're not getting that, then I would encourage them to seek out somebody who will really take a personal interest in their medications and helping them manage them as safely as possible. And also pharmacists have a more complete picture of over-the-counter prescription medications because they're often right there at the point of sale, and they're in a great position to recognize duplicate medications, drug interactions, not with just the prescription meds, but with their over-the-counter medications, their herbals, their vitamins. All of those are important pieces of an overall picture of what medications a patient is taking. So I thank you for your time and hope that this was helpful in giving you an understanding of medications and their risk of fall in elderly patients.
Thank you, Leah. Please hold your questions until the end of the panel. We will have a discussion with all of our panelists at the end of the webinar. Next, I'd like to introduce Jennifer Dugan. She's a primary care clinical pharmacy specialist at Kaiser Permanente.
Thank you, Melissa. I'm delighted to be here today. I was asked to talk a little bit about some strategies that we've used at Kaiser Permanente, Colorado region to try and reduce potentially inappropriate medications and hopefully be able to reduce the incidence of falls. So as you may know, Kaiser Permanente is a not-for-profit healthcare system, and we have one of our regions is here in Colorado. There are expansive clinical pharmacy services here that are integrated into the care team. So we have primary care, clinical pharmacy specialists. We have them in continuing care, which is our geriatrics team that goes out to skilled nursing facilities, as well as centralized services such as those who deal with anticoagulation or cardiac risk. So the clinical pharmacy specialists partner with providers and with the dispensing pharmacist in what we call pharmacy operations. And in addition to affordability and service, there's also a big focus on quality and HEDIS measures within our program. And HEDIS measures, as you may know, are a measurement of quality that healthcare plans are measured on in comparison to one another through the National Council on Quality Assurance. So to just kind of reiterate some of the information that Leah shared, the drugs to avoid in the elderly, the list that Leah covered is pretty extensive, unfortunately, and our first exposure to this was many years ago through the Beers list, which you may have heard, or the Beers criteria, which was actually just recently updated this year to help us target certain medications that should be avoided in the elderly, primarily due to the fall risk. Additionally, all healthcare plans are measured on a HEDIS measure of drugs to avoid in the elderly, as well as a separate HEDIS measure that's drugs to avoid in the elderly for certain conditions, and one of those is patients who have already had a fall. And in general, all these lists have similar high-risk medications. So, for example, diazepam or Valium that Leah spoke about is generally always on the list. Promethazine or Phenergan is generally on the list. Skeletal muscle relaxants such as Soma or Flexeril are on the list. Amitriptyline, which is one of the tricyclic antidepressants that Leah mentioned, is on pretty much every list, as well as antihistamines, the more sedating ones such as the Benadryl or the Atarax, and anticholinergics that can be used for different indications, especially for urinary incontinence or for GI issues. So I wanted to talk a little bit about some of the pharmacy interventions done to try and reduce the risk of the use of these medications in patients who have either had falls already or who are obviously at high risk for falls just due to their age or their frailty. So the first thing that we spend a lot of time doing is education, which I'll talk about more in depth. We also have a pharmacy intervention that is done at the time of prescribing of a medicine, a high-risk medicine that the patient has not yet received. Additionally, we've done several clinical pharmacy conversions where we try and switch from a high-risk med to a lower-risk med, though they're not always risk-free. I'm going to talk a little bit about best practice alerts in our electronic medical record, medication therapy management, and some Medicare 5-star initiatives. So the first thing I want to talk about is education, and this primarily goes to providers who, definitely understand that there are high-risk medicines, but I think sometimes the risk is known in theory, but not necessarily like how strong the evidence is for some of the medication classes. So in general, we've done individual topics. So for example, when we target one particular drug class like skeletal muscle relaxants, and we look at the evidence and say, there's not great evidence that they work in the elderly, and then there's certainly some risk of falls associated with it. We tend to take that topic and try and educate providers. This can be done in a variety of ways, but generally we include it in a provider newsletter, as well as have a clinical pharmacy specialist present the actual evidence to providers. In general, the pharmacist would partner with a geriatric physician champion, so it doesn't feel like it's the pharmacy police coming and trying to tell the provider what to do, but instead have a geriatrician also involved in the education. And we always try and educate prior to doing an intervention such as a conversion. The next topic I want to cover is a pharmacy intervention that we started several years ago. It was actually a prospective randomized trial done at Kaiser, Colorado for all patients age 65 and older. And the intervention was a pharmacy alert fired in the pharmacies for when there was a new start of a targeted medication, a targeted high-risk medication such as the amitriptyline or other medications that would not be appropriate in a patient over age 65. And then the dispensing pharmacist called the provider to make sure that they really wanted to use that medicine. So we had, at the time, we had about 58,000 elderly members, and half received the intervention and half did not. And what was seen was that there was a reduction in the in the number of patients who received a high-risk medication in the intervention group compared to placebo. You can see the numbers are fairly small, but that's because, thankfully, there weren't a lot of prescribing of these high-risk meds to elderly patients to start with. The primary medications that we're seeing were amitriptyline, which is again is a tricyclic antidepressant, which has strong evidence for increasing the risk of falls, and diazepam, which is a long-acting benzodiazepine, which also has pretty strong evidence for increasing the risk of falls. So the intervention continues today with a smaller targeted list in all our pharmacies. Luckily, they don't have to call as often because the providers are used to receiving those phone calls. We've also done some clinical pharmacy conversions where a clinical pharmacy specialist for example, in the primary care setting, gathers a list of patients on either a high-risk medication or a combination. And this is decided at a high level kind of what the next targeted group would be. So our continuing care specialists and our primary care specialists often work together on this. The biggest intervention that we've done in recent years was on diazepam, which is one of the long-acting benzodiazepines. And at the time, the evidence suggested that it was probably safer to convert to a shorter-acting one. That has definitely come into question now, but there were patients who were also able to get off the diazepam if they didn't have an indication or once they the safety information was reviewed. So we were able to convert patients to at least a shorter-acting benzodiazepine and then take some patients off. We've also looked at different conversions or different categories. So for example, there are patients who take what's called a cholinesterase inhibitor, which is basically a medication that increases acetylcholine in order to treat dementia. And then they would also take an anticholinergic, which decreases the acetylcholine and makes cognitive state worse. So we had patients who, and this goes on all over the country, there are patients who are on the combination, and if the anticholinergic is one that crosses into the central nervous system, as Leah talked about, then they basically interact and completely negate any benefit for the dementia. So we've looked at these groups. We've looked at patients who are on skeletal muscle relaxants, hydroxyzine, which is another high-risk antihistamine. And in general, we're already trying to look at antipsychotics to try and make sure we're not leaving patients on antipsychotics if they can come off due to not just the increased risk of falls, but also the increased risk of mortality. We also have the advantage of having an electronic medical record is the ability to create best practice alerts that will fire at the time of prescribing. So this gives the provider a chance to change his or her mind at the time that they're, they may be seeing a patient who looks very good and they're not registering that they're, 68 years old and that the medication that they're thinking about may not be the most appropriate for them. The best practice alert fires with a list of alternatives, so the patient can, so the provider can actually pick an alternative medication that would be safer right there at the point of prescribing. And we have seen a reduction in prescribing of high-risk meds through this process. When we have sometimes challenging medication classes, for example, skeletal muscle relaxants has been harder because, sometimes the patient comes in and specifically asks, like, please give me my Flexeril. It always has worked in the past. So sometimes they would override the best practice alert, but if it's something that we're seeing a lot of overrides, then we can have that alert the clinical pharmacy specialist to at least have a discussion with the provider and answer any questions about it. As you may know, medication therapy management, or MTM, is a thorough review of medications that is mandated for certain patients who are covered under Medicare. And in Kaiser Permanente, Colorado, our clinical pharmacy call center does MTM reviews for the appropriate patients. And one of the big components of this is drugs to avoid in the elderly, or basically looking at patients who are on potentially inappropriate medications and trying to address that. The pharmacist sends a note to the provider with recommendations on alternatives and is able to, search our electronic medical record for previous medications that have been tried within our system, so we have a sense of, if the patient has failed everything else, then it might be okay to continue, but if there are alternatives, and risks outweigh benefits, then it certainly should be something that is switched. Our call center pharmacists are also involved in skilled nursing facility discharges. So basically a patient goes into the hospital, and if they need additional rehab or additional skilled nursing care, they would go to a skilled nursing facility. At that point in the skilled nursing facility, they have had home meds, then they've had different medications in the hospital, and now they've had a third group of medications in the skilled nursing facility. And then they go home, and now they have medications in a bubble pack that they receive from the skilled nursing facility. They have all their medications at home, which may include medications that caused the problem which got them into the hospital. Half the doses have changed, and so our call center pharmacists outreach the patient within their first 24 to 48 hours at home and do a very thorough review, tell them which medications to get rid of, make sure they're not doing duplication of their blood pressure medicine from the skilled nursing facility that's the same as their blood pressure medicine they have at home, but because one has a generic name and one has a brand name, they take both and then they fall over. So we're really trying to address some of the most common places and most common times where medication errors can happen. Finally, I want to talk just briefly about the Medicare 5-star initiatives. As you know, Medicare health plans are rated on a Medicare 1 through 5-star, and that determines a lot of the financial incentives that healthcare programs get, as well as the ability to enroll patients year-round. And when we looked at our Medicare 5-star, we did very well, but there were a couple areas that we did not do as well at and in our first year, and one of those was that we did not excel at identifying patients who have had falls in our system. We also didn't excel at getting patients off medications that could be contributing to falls. So it was something we had been working on, and in certain HEDIS measures we did very well, but specific to falls we were not doing that well. So the multidisciplinary outreach that happened was there was a phone outreach from a nurse to ask patients about whether they'd had a recent fall or had a fear of falling, and this occurred prior to their annual visit with their primary care doctor. If it was positive, then a clinical pharmacy specialist did a review of the medications. And what we found was that, luckily, there were minimal high-risk meds when we looked at the overall group of all patients who reported a fall or a fear of falling. So thankfully, it had already kind of been addressed. So in order to have more impact, we changed the intervention to just those patients who were on high-risk medications and saw more success in getting the patients off, and it decreased the workload if we only looked at patients who were already on a high-risk medication. So some of the new challenges we've seen, as Leah alluded to, the list of medications that can contribute to falls includes what we call Z drugs, or the sleep medicines like Ambien or Lunesta or Sonata, and that is now on the list of for the 2012 Beers criteria list, and it's also been adopted, that particular list, for the new HEDIS measure for drugs to avoid in the elderly. And in our system and nationwide, just like Leah spoke about, these were drugs we thought were safer, and the evidence has come out showing 2- and 3-fold risk of fractures for the patients who are on these drugs. So this is our new area of opportunity, is how to address patients who are already on it, how to educate providers that there is this substantial risk when it initially was thought to be safer.
Thank you. Thank you very much, Jennifer. Now we're going to go to the phone. Our next speaker will be Vicki Cassabaum. She's an injury prevention coordinator for the trauma service at St. Anthony's Hospital.
Hi, can everybody hear me? This is Vicki Cassabaum. I was asked to just briefly speak about bringing it to the community and doing a small presentation with your community group and how you can get the medication message out. Generally, I have a small little grant with West Metro Fire and the Lakewood Rec Center here in our community, and one of our days is basically dedicated to medication review and identification. And one of the key things that we have found with doing our little project is just that we're trying to introduce them to best practice in fall prevention and introducing them to the multifactorial approach. And so we're just kind of giving them a taste of what needs to be done in order to help prevent a fall. So as far as the medication review, what we're doing on a local level is on our first session, we're sending them home with a file of life or a list per se, that we give them homework to go home and actually record their medications as they're written on their prescription bottles and their over-the-counters and that sort of thing. When they come back for our session, we actually, the next week when we do the medication review, I as an RN basically go through the whole medications as outlined by Leah and our previous speaker as to the high-risk meds, give them some kind of side effects and some effects that are expected and how they interact, and just give them some best practice recommendation about education, but about the meds. But our biggest focus is actually on empowering them to be advocates for their health care and making sure that they are keeping a list of their medications, that they are discussing it with their primary care physicians, that they are taking it to every visit that they have, that they understand that the reason they're taking the medications, the dosage, the timing, and all those medications that can interact with the meds, that they have a clear understanding of that. And we just go from person to person and look at their list and kind of point out, this might be an issue for you, this might be one you want to discuss with your doctor. Because at the local community level, when you're doing just a small presentation, I have no control over making any changes, but I can kind of make recommendations to them that they can then take to their provider. Because one of the things we've found with dealing at the local kind of community level is that a lot of older adults don't know how to talk to their physicians and don't know how to talk to healthcare providers. So really it's just more or less going through and helping them feel like they can talk to their physicians about what medications they're taking and the risks and side effects and how that can be affected. So that's all I have. Melissa just wanted me to give a brief synopsis on how to bring it to practice in the community.
Thank you, Vicki. We'll ask you to stick around for some questions later. This is our last presenter now. Alondra Milthorpe is a life solutions specialist with the American Red Cross. She's here to talk about helping older adults on complex medical regimens remain independent.
Hi everybody, it's Alondra. I am with American Red Cross, and we are very busy right now, if you were thinking that. We are partnered with Philips Lifeline, have been for quite some while, and the reason why we're partnered with Philips is to help our senior community prepare, prevent, and respond to their disasters. So having a fall or losing their independence can be a disaster. So kind of to sum up what we're going to talk about here with the medication dispenser is how folks can stay at their home and take care of themselves with the help of a dispenser. So I'm going to kind of slide through some of the slides and get to our first one with medication non-adherence and how it can be pretty costly to our healthcare system, and everyone knows how that's going. So I won't go over too much about this slide, but if you have any questions later, let's send me an email or something like that. But we do know that multiple medications folks are taking at a time can be complex, and they're at greater risk for having to fall, and some of them have some cognitive impairments that make it difficult to take their medications on their own and may need some help. So our next slide goes on to the options for managing medications. So we start to see, some of the folks you may be dealing with, they have those Monday through Sunday boxes, and those can kind of get confusing. And then we might go to those pill boxes that have like a light or maybe something that talks to them. And then we go to the next step, which is the medication dispensing service that we have with Philips. And then you might have the next step where it goes to the assisted living nursing home and where the person can no longer be taking care of their own medicine regimen. So how the service works, I actually have a DVD for that. Let's see if we can try to get that going. We're trying to be computer savvy over here. Hopefully everyone will be able to see it and hear it.
The Philips Medication Dispensing Service is designed to simplify complex medication regimens, help reduce errors that can lead to medical complications, and provide both caregivers and patients peace of mind. Here is how it works. When a scheduled dose is required, the dispenser button flashes on and off, and the medication dispenser sounds a vocal alert. Time for your medication. Press button to dispense. All the patient needs to do is press the button and the dosing cup will drop. Thank you. The patient simply picks up the cup, removes the cap, and takes the medication. To make sure the patient is notified of the scheduled dose, the voice prompts will continue every minute for up to 90 minutes until the button is pushed. Time for your medication. Press button to dispense. If after 90 minutes the patient does not respond, the dose is automatically moved to a reserve bin inside the locked dispenser to prevent the risk of an accidental overdose, and the caregiver is notified. Hello, this is the med dispenser calling. Your patient has missed their medication. This alert allows the caregiver to step in and resolve the situation properly, ensuring that patients adhere to their medication regimens. The Philips medication dispenser also has a low dosage alert that prompts a call to the caregivers 3 days before the programmed medication runs out, and an alert when it's time to refill the dispenser. In addition, thanks to the medication dispenser's large capacity, a caregiver can pre-plan for unexpected issues.
Hi, Mom. My flight has been canceled due to bad weather, but I've loaded an extra 4 days of medication into the dispenser, so you should be fine until I get home on Thursday.
Another safety feature is the backup battery system. If power goes out, the medication dispenser will continue to dispense for up to 18 hours. In addition, the medication dispensing service will automatically alert the caregiver of a power outage. Your patient's electricity is out. A feature especially helpful during very hot or very cold weather. For seniors and other patients with complex drug regimens, the Philips medication dispenser is more than just a tool. It's a life-changing solution. With storage for up to 60 cups, you can load from 1 to 40 days of doses, deliver a 98% adherence level, and offer caregivers relief and peace of mind with a comprehensive 24-hour monitoring and voice alert system. By delivering a better way to help with medication management and reduce errors, this service is a worthy addition to the Philips brand.
Okay, well, since we're not taking questions right now, current slide. So the video sums it up really nice and well. So what will happen is the dispenser is professionally installed, and the caregivers, usually family or professional healthcare provider, are trained during the installation on their role in the medication management process. The installer will set up the dispenser, download the required schedule for dosing, and then the phone contact information for the caregivers that are requiring the alerts. So the video went over the key features. What it doesn't talk about, like, the safety feature, the PRN on-demand medications. What's a neat feature is, so if someone's, let's say, comes home from a back surgery and they're allowed to take a pain pill every 4 hours, they can wake up, press a button, it will dispense, and they're like 2 hours later, oh, I think I need that pill. They can try to walk up and press a button, but it won't dispense until those 4 hours have been allotted. So that's a very nice feature as well. And it is an automated voice, and she does say time to take your medication. There are also 23 pre-recorded messages. It won't hold any liquid medication, so if someone's taking insulin, one of the recorded messages can be time to take your insulin, remove patch, put patch on, may cause drowsiness, take with food, and a couple other messages as well. So there's also online reporting, which is really nice. So if I want to, let's say, for example, watch over my mom who's in Texas, I'm like, I don't want to get a call every day because my sister's taking care of her, but I want to go online and see how she's doing. I have the accessibility to go online and see how often she's taking it. And if I need to show to the hospital, you know, she's taking her medications on time, everything is going correctly here. I think there's something wrong with the pill or the dose. You can go on and so forth with that. So who could use the medication dispensing service through Philips? People with more chronic conditions or taking multiple medications. They're very complex medicine regimens. Definitely someone who wants to stay in their home and be independent. Also, it could bring some independence to maybe those family members that are coming over there all the time, who are filling those Monday through Sunday boxes, and they want some independence to say, Mom, I don't want to come over every couple hours and worry about you, so let's get this medication dispenser so I don't have to worry as much. The next kind of going into it, maintaining independence with our lifeline, and that's a personal emergency response system, and that can be done at a later time. So I kind of rushed it, but the video went over it really well. If you have any other questions, you can always give me a shout or an email, and I can get that to you later.
Thank you. Now we're going to begin our question and answer portion of the webinar. Just give us one moment to unmute folks, and we will get started with that. We're all unmuted. Okay, everyone should be unmuted now. Are there any questions or comments for any of our 4 presenters today?
Does the medication dispensing require a landline?
As of right now, yes.
Okay, any other questions?
I have a question as far as on that medication dispensing. Is that covered by any insurance, and what is the general cost to the patient?
Great question. So with American Red Cross, we do not get involved with Medicaid, Medicare, or long-term insurance. We do private pay. Now, if you're working with insurance companies and they deem it as long-term care, I have heard they'll cover it, but I'm not the expert to know that. Through American Red Cross, if someone wanted to get the service, they can contact me or the 1-800 number. Right now, it's about $75 a month. That's month-to-month basis. There's no long-term contracts.
$75 a month for the pill dispenser.
Pardon?
Okay, Eddie. Someone speaking, I'm not sure if you're trying to ask a question. If you are, please speak more clearly so we can hear you. Okay. I'm not hearing any more questions. I don't see any questions submitted on the computer either. So unless there are any more comments from our panelists, I think we're going to wrap this up. Okay. All right. Well, thank you for joining us today. Please don't forget to come to our next webinar on November 19th, which is titled Vision Exams and Vision Improvement. Again, we thank you for attending today and your participation, and we look forward to seeing you on the 19th.